Hello, everyone. Jim Tedrow, sheltering in place in Oklahoma City today, sort of. Thought I would reach out and thank everyone for all the support and the responsiveness that I've received over the last 24 hours or so since the publication of the Santa Clara County Seroprevalence study for COVID was published and my connection to that was established. Have heard from a lot of folks and appreciate all the kind words and the support from lots of people. So I want to say thank you for that. And then also have had a lot of questions come in about the study itself, some other questions sort of related to COVID, and thought I might just take a little bit of time to discuss some of those things and maybe provide a little bit of insight into both the study that I participated in Santa Clara County, and then also some other sort of COVID related questions that I've maybe gained a little bit of insight into over the last few weeks or month while working on this. So one of the big questions that we get is why did you do the study in Santa Clara County? What was it designed to do? And simply put, the goal of the Santa Clara study was to identify the prevalence of COVID infections in that population. And to date, we're all very familiar with the number of confirmed cases. That's the number that we see on the news every night. It's the number that continues to climb. And those are the number of cases that have been actually diagnosed and confirmed with a PCR test. And but is that truly reflective of the total number of infections? We don't know. So we wanted to perform a study to really try to gauge the number of infections, and then we can use that to better identify where we're at in terms of the prevalence of the virus and potentially how deadly the virus is in terms of a true infection fatality rate. So the way that we decided to do this, as compared to the PCR test, which is a nasal swab or potentially a throat swab where viral genetic material has to be present on the sample in order for the test to be positive, which is a great way to identify a current infection. But if the patient has had the virus previously and possibly they were completely asymptomatic or mildly symptomatic or maybe even really sick but were never tested, then the PCR test is not going to provide an indication that they've been exposed to the virus because the virus has already gone if they're recovered. So we chose to utilize serology, or a test for the presence of the antibodies to COVID. And this was a better way to monitor population prevalence, simply because it provides a long window that we can look back through to see if there's been exposure to the virus. Your body produces antibodies to any number of pathogens when you're exposed to them, and those antibodies will stay detectable in your blood for a significant period of time after that exposure. So we felt that serology was going to be a much better tool by which to gauge uh, true population prevalence, because it not only looks for current infections, but allows for a historical perspective on whether the person has been exposed to the virus. So a common question that we get is, what testing device did you use, and was that device any good? And we used a rapid lateral flow immunoassay test that was distributed by Premier Biotech. The device was Premier Biotech is an American company, but the device was manufactured in China. Uh, the big question is, was your test any good? Well, we had performance characteristics that were published by the manufacturer, and when we reviewed those, they looked very, very good. But we had questions about whether or not we could really trust those, and we didn't want to rely solely on the manufacturer's claims in terms of the performance of the device. So we performed two separate validations of our test devices in two independent laboratories at Stanford. The first of those validations, the validation data is included in our initial study submission. That it is included in the initial manuscript that's available now. The second validation was completed subsequent to the upload of the initial manuscript. So it will be included in subsequent versions of the published document. And both of our independent validations showed good performance from both sensitivity and specificity of the device that we utilized. No diagnostic test is ever going to be 100% sensitive or 100% specific over a large number of samples, but we felt that the performance characteristics of this device were certainly adequate for the application that we were using it for. Next question, why did you use Facebook to obtain a sample population? Well, obtaining a good sample population was a challenge throughout this process, and really that part of the study was not something that I was heavily involved with, but I can speak to it just kind of in generalities. We realized the importance of obtaining a representative sample population and doing everything we could to obtain that representative sample. There were challenges really anywhere we turned with that, and there was going to be inherent bias regardless of which mechanism that we utilize. So the benefit of the targeted Facebook advertising is that it can become pretty granular in terms of controlling where those ads go. And while we knew that there would be bias that would have to be accounted for in the population, we just kind of had to pick a way to develop a population sample in a relatively short period of time. We understand that there is probably a lack of true representation in certain demographics. I also think that lack of representation, which often are tied to, in order to enroll in a study that's promoted through Facebook, you obviously have to have access to the internet. You have to have access to an electronic device by which you can complete the survey and enroll. So inherently, there may be a bias just simply from those two requirements. We do feel strongly, though, that bias, acknowledging that it exists, probably would actually result in potentially an under prevalence of lower socioeconomic individuals. And so, and we know that disease prevalence tends to run higher in those populations. So actually, the bias may actually skew our results downward, if anything. And those biases were accounted for in the study, the final study calculations, and to the best of our abilities. And so that's a very generic, basic description of why Facebook was used to develop a study population. Okay, what were the results of the study and what might they indicate about the COVID pandemic? So the results of our study showed that an adjusted rate of prevalence of 2.8%. So basically 2.8% of the people that participated in our study showed the presence of COVID-19 antibodies. And so what that really means over a large population basis is that, there's roughly 2 million people in Santa Clara County, and 2.8% of those are going to have COVID infections. So that's anywhere between, that's roughly on the low end, 50,000 people. 2.8% of 2 million people is going to be 56,000 people. And at the time of our study, we had 956 confirmed COVID cases in Santa Clara County. So that's roughly what we call, that's an infection to confirmed case ratio of roughly 50 to 1. We refer to that as under ascertainment, the number of infections that are not diagnosed as confirmed cases. So there was a range of that was given in the study of anywhere between 48 and 85 times the number of cases to or infections to cases. And that was the real takeaway from the study. Not so much the 2.8% number, which is indicative that a lot of people don't have the antibodies and have not had the virus, but simply that there are a lot more infections than we have confirmed cases. The meaning of that is, and the significance of that is that it allows for a better estimate of infection fatality rate. Infection fatality rate is the number of people that are infected that end up dying from the disease. And so, if we look at the news every night and we see across the United States, X number of confirmed cases and X number of COVID deaths, then we can do the math using deaths as the numerator and confirmed cases as the denominator, and we get some pretty scary numbers. 3.5, 4, 4.5, 5% confirmed case fatality rate. And when that happens, that creates a lot of fear. Well, it's not necessarily representative of the true infection fatality rate. If you apply the numbers that we found in terms of under ascertainment, and you multiply the confirmed case rate by 50, well, now we've got a significantly greater number of infections, which then replaces our confirmed cases as the denominator in that equation, and that dramatically lowers the infection fatality rate. And it gets us down somewhere around 0.1 to 0.2 of 1%. So 1 to 2/10 of 1%. And which is, the seasonal flu has an infection fatality rate of approximately 1/10 of 1%. And so the takeaway is that it appears that the infection fatality rate is down in the neighborhood of seasonal flu. And that's really good news in the sense that it's not as deadly as the statistics that you see on the news may lead you to believe in terms of the number of people getting the disease and ultimately dying from it. It's an order of magnitude or more less significant than what it would appear when just comparing confirmed fatalities or fatalities to confirmed cases. Now, that doesn't mean that this is the flu. It's clearly not the flu. It's very contagious, and there's no vaccine. So, while we can compare infection fatality rates between COVID-19 and seasonal influenza, and those numbers are valid, and they do shed some light on the lethality of the disease, they don't necessarily suggest that the two viruses are the same, because of some various factors. So, and those factors really have to do with the lack of a vaccine. We don't have a vaccine for COVID. One of the things that the flu vaccine allows us to do is control the spread of the infections. And we don't necessarily have quite the ability to do that with COVID through vaccinations. So, and it also appears to be very, very contagious. The mechanism by which it's spread is slightly different than the flu, and so to be clear, this is not the seasonal flu, even though the infection fatality rates between COVID-19 and seasonal influenza may be the same. So we've kind of talked about why is the number of confirmed cases so much lower than the estimated infections. Well, that kind of goes back to the testing that's being done. As I mentioned earlier, the diagnostic gold standard is real-time PCR. and it's a nasal swab that looks for viral genetic material. So the virus has to be present. So the virus is typically only going to be there for, I mean, depending on the length of the infection, yeah, maybe a couple weeks, 7, 14 days, 21 days, depending on the length of the infection. So you've got a relatively narrow window of time by which to get a sample on a person that's going to suggest that they have been infected with COVID. Another limiting factor has been that due to the shortage in test kits, um, there's been relatively strict criteria that had to be met from a symptomatic um, perspective to even qualify to receive a test. So there's been a lot of people that are sick, but still didn't qualify to get a test according to the CDC guidelines. So it really kind of comes down to, in a nutshell, a real lack of testing overall, and also the type of test being utilized providing a relatively narrow window to indicate that somebody has had the virus. So, how do the results from Santa Clara County, how might they be extrapolated out over other geographic areas? Well, that's a great question, and it's not really one that we can answer. I think that the takeaway from the Santa Clara County study is certainly that the number of infections is dramatically higher than the number of confirmed cases. In our study, it was between 50 and 85 times higher. I think if you went from different geographic locations uh, around the country and performed similar seroprevalence studies, I think that you would find the similar trend of greater infections than cases. To what degree, we don't really know. It may be 20 times greater in one area, it may be 100 times greater in another area. And that's why we really need more seroprevalence studies performed across the United States. They're going to be a really good tool to identify the prevalence of the virus and allow for more informed public health policy to be made. And it also kind of suggests that the notion of flattening the curve, um, which it has been the battle cry throughout this entire process, is, in my opinion, a little bit misleading. I don't think there is a curve. I think there are a whole bunch of curves, and each demographic or geographic area and each group of populations has its own curve to a certain degree. The curve in Oklahoma City, I would suggest, probably does not look anything like the curve in New York City or other areas of the country. So really, individualized seroprevalence studies in multiple geographic locations across the country, I think will provide a great tool in order to be able to shed light on where that individual community is at with the virus, what the prevalence is, and then what are appropriate steps and policy moving forward. So, how does this information help guide our response to COVID moving forward? Well, that's not really the purpose of the study. We all have our opinions on what the best response to COVID is. I think that I think that the results of our study provide one key piece of information, um, uh, really two key pieces of information. One of which is that the number of infections is dramatically higher than we may have originally thought based on confirmed cases. And two, that the fatality rate associated with those infections is dramatically lower than what we've seen with confirmed case fatality rates. And those are both good things. I mean, there's a lot more people that have had the virus than we knew, and the vast majority of those have survived. When we watch the news and we see statistics that suggest, 3.5 to 4, 5 people out of every 100 confirmed cases are dying, that's very, very scary. Much more so than the true infection fatality rate, which may be somewhere between 1 and 2 people out of every 1,000 infections dying. So the results of the study are good in that regard, and they will allow public health officials and policymakers to be more informed as they move forward. It doesn't it does not tell us that this is the flu. As I mentioned earlier, we don't necessarily have quite the same mechanisms in place through vaccines to control the spread of the virus. So without question, we know that we have to continue to protect those that are at high risk groups, elderly, immunocompromised, underlying medical conditions. We also need to be very mindful of um, uh, health system infrastructure and monitoring where we could potentially have outbreaks or flare-ups, and making sure that we provide infrastructure for healthcare systems in those areas so that they don't get overrun, and we have an infrastructure failure of any kind. So, it's a really good, useful data point and piece of information. It doesn't solve all the COVID questions or problems, but it's a good piece of data uh, to help us move a step closer to doing that. All right, so there's been some other questions kind of floated out there, and just kind of a lot of, I think, information in the media that aren't directly related to our study, but I may have some thoughts on, just simply due to my role in the study. And so the first one is, what is an antibody test, and what exactly does that tell us? Well, as I mentioned earlier, your body produces antibodies when it's exposed to a pathogen, and it does so in phases. The first antibody that your body produces is called IgM. It's an early, quick phase response designed to just go and neutralize whatever the pathogen is, in this case, COVID. And that antibody is present typically anywhere from maybe 3 to 7 days after you've been exposed to the virus. So you'll actually have an immune response relatively quickly after the virus has you've been exposed to the virus. Then our body kind of has a really cool process of developing a long-term immune response, and that's through the production of a second antibody called IgG. And IgG is produced a little bit later on in the immune response, maybe 10 days to 2 weeks after exposure to the virus. And IgG serves as somewhat of a memory response. So the next time that your body is exposed to whatever pathogen the antibody was created to fight off, then your body remembers how to react to that. And it does that through the IgG antibody. And so your body is prepared to mount a much quicker and much more specific immune response to that pathogen the second time that it sees it. Now, the question that seems to be floating out there is, how can we use antibody testing? And what does the results? My antibody test was positive. What does that mean? What does that allow me to do? How can we use these tests? If I produce the antibody, am I immune to COVID, and those sort of things. So, I think right now the antibody testing that we've done that is currently available is very useful for the application that we applied it to in the Santa Clara County study. It's very good to identify exposure to the virus on a large scale, on a population basis, and to make some assertions about how many people have had it, and then extrapolate kind of what those figures mean in terms of where we're at with the virus, and what how lethal it is, and those sort of things. What the antibody testing that's currently available can't really do is provide a lot of insight on an individual case basis. So, we tested 3,300 people in Santa Clara County, and we came back and said 2.8% of them have the antibodies. And that's really about it. What we do with the people that comprise that 2.8% and how we would advise them, we simply don't know. What we can tell them is that it appears that you've had an immune response to COVID, which is a good indicator that you've had the virus at some point in the past, or you currently have it right now. And so, but we can't necessarily direct them on a course of action on an individual basis moving forward. So the prospect of utilizing these antibody tests to establish immunity and therefore allow somebody to move about, in a more relaxed fashion. I just don't think we're quite there yet. Um, we don't know necessarily that the antibodies that are produced necessarily confer immunity. We think that they probably do, but more research needs to be done to verify that. We also don't know how long the antibodies will last. They may last for a long period of time, but we don't know what that is. And then the rapid tests, like the one that we used in the Santa Clara County study, are simply a qualitative test. They don't tell us the amount of the antibody that's present. They're simply a positive or negative test. It's either there or it's not. They don't tell us how much of it is there. And really, in typical serology testing, the way that immunity is established for something like hepatitis B or measles or mumps or varicella or anything like that, is that we test for the antibody in the blood, we quantify the amount of the antibody that is present, and then we can compare that to standards that we have identified as suggesting immunity. So while we're very close to being able to identify and even potentially quantify the amount of the antibody in a person's blood, we don't necessarily know what standard we need to compare that to demonstrate or to verify immunity. So it's just a little bit too early in the game. I think the antibody tests have promise in terms of being able to be a tool that can be used to potentially direct people at some point in the future. We're just simply not there quite yet. And to be clear, that's the purpose of our study was completely unrelated in any form or fashion to try in trying to establish that any individual has immunity or to suggest that they can act in a different manner based on the positive or negative results of their test. So with that, I think I've probably put most of you to sleep. Hopefully you're having a great nap on a Saturday afternoon. And if there's more questions, feel free to reach out. Again, thank you for your support, and I look forward to a return to normalcy sooner than later, and wish everybody a safe rest of the weekend. Thank you.